Good morning, everyone. I'm Diane Perez, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Prevention of Synthetic Drug Use. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options will be posted in the chat panel too. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen, as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 5 business days. To access the recording, go to www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants within that same time frame. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website. You will first need to register or sign in to your account to complete the evaluation. Information you provide FADA as part of registering remains confidential. Statements of credit will be posted within 10 business days after the evaluation closes in individual professional development journals for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Do note that the evaluation will close at midnight on Thursday, January 31st. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you don't need to provide your certification number when you register with our site. Note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. Dorothy Chaney is the founder of Wisconsin Community Health Alliance. an organization committed to supporting coalitions, agencies, and individuals to improve the health of their communities and the environments in which they live. Chaney works nationally and also locally to address health disparities and support the development of local solutions to complex problems. For more than 20 years, Dorothy has worked with community-based coalitions throughout the United States, supporting their efforts to combat the impact of substance use on youth and families. Dorothy has also served on many state-level work groups and advisory committees in Wisconsin. Chaney also works with communities to implement collective impact and results-based accountability approaches as a strategy to improve community health. Dorothy is a consultant with the Community Anti-Drug Coalitions of America and has also consulted on a variety of projects for the Substance Abuse and Mental Health Services Administration, and is a nationally recognized trainer and public speaker. In addition to being committed to supporting communities in public health efforts, Dorothy is a strong youth advocate and currently serves as an elected Board of Education member in Marshfield, Wisconsin, where she resides with her 2 daughters. Prior to moving to Wisconsin in 2006, Ms. Chaney served as the State Executive Director for MAD in Minnesota. Chaney has a bachelor's degree in political science and a master's degree in adult education. And now I'd like to welcome our presenter, Ms. Chaney. I will turn the presentation over to you, and thank you so much for joining us and being with us today.
Thank you, Diane, and welcome everyone. Again, my name is Dorothy Chaney, and I am working with an organization called Wisconsin Community Health Alliance. So I don't know if you've been watching the weather, but for those of you who are calling from warmer destinations, which all of you are because you're in Florida, we're on our 2nd snow day from school here in Wisconsin, and I think the temperatures are reaching about minus 40 degrees with the wind chill today. So if you haven't given thanks today for where you live geographically, this is just my shout out to say you might want to do that at some point today. And thank you so much for inviting me back to do another webinar with FADA. I think this is my 3rd or 4th opportunity to do projects here in Florida. And while I hail from Wisconsin, St. Petersburg is my 2nd home, and I'm in the process of moving to St. Pete. So Florida is near and dear to me, and I've actually worked with many, many communities all over the nation, but many communities within Florida. And I also work on the international level, and in fact, we'll be leaving for Albania on Friday to work with 2 cities there. So I spend most of my time in prevention, and really am excited to talk with you today about the prevention of synthetic drug use. And I am really excited particularly about the opportunity to listen to some of your questions. One of the great things about the webinar format is it enables you to do continuing education from your office or wherever you can call in from. One of the downsides is it's difficult to see, obviously, the participants and hear your questions throughout the session. So we really encourage you to use the chat or the Q&A box. Diane will be monitoring that as well as I will too. And let me just say, Diane, I invite you now to stop me midstream if there's a question that comes in. One of the dynamics of the webinar is I'm going to make sure that the airtime is filled, but I really want to make sure that we infuse those questions that come in during the webinar, because that's what makes the learning rich and full. So I encourage you to ask questions throughout. The way that I build webinars is I account for 15 to 20 minutes worth of questions. The last webinar that I did with FADA, we had more than that. So I'm hoping this time that we'll have lots of questions as well. Again, I'm presenting the information, but really the questions that you have to help inform your work will really make this a good use of time for everyone. And before I jump in, I also want to say that I know that some of you are representing agencies through a prevention lens. Some of you are also probably representing or part of community-based coalitions. And as we jump into this, we'll see that the Substance Abuse and Mental Health Services Administration really does encourage collective impact or coalition-based prevention strategies to address emerging trends as well as existing threats to our youth in the community. So I'll be speaking to both individual agencies and coalitions as we go through this. For those of you who are working on the treatment realm, I hope that this will also be helpful and inform your work, because we're all connected to the work, just in different entry points. And so it's my intention to provide some nuggets of information that will be helpful no matter where you fit on the continuum of care. So moving forward, Diane, I'm getting a bit of a technical difficulty. I can go back, but I can't go into the next slide.
I'm going to take over the controls real quick, and then I'm going to do something here.
Perfect.
And now try.
That's it. Thank you so much.
Thank you.
So today we're talking about addressing the impact of synthetic drugs, a prevention approach. So our learning objectives over the next 2 hours are to learn about the classes and the types of synthetic drugs and their effects on the body. And we're going to discuss how to apply SAMHSA's strategic prevention framework, so the Substance Abuse and Mental Health Services Administration's strategic prevention framework to diagnose local synthetic drug trends and issues. And we'll also spend a little bit of time talking about how to examine how to use the strategic prevention framework to engage key community stakeholders in the development of an action plan to combat synthetic drugs. And we'll spend just a moment talking about proven effective strategies to prevent and reduce the impact of synthetic drugs. Now, I need to mention that this could be a full-day training, if not more. So really, my intention in this webinar is to introduce the topics to you. And I also have to say, if you have follow-up questions or want more information about any component that we cover today, certainly connect with FADA and they can provide my contact information. And I'm happy to follow up after this presentation to ask any additional questions or to provide resources that go a little bit deeper into some of these concepts that we talk about. So the background and history of synthetic drugs. So setting the stage, synthetic drugs are chemical compounds that are produced in a laboratory. And especially when we think about things like synthetic marijuana, people may often have the misconception that these drugs are similar in some way or mimic the chemical compounds of marijuana, which is an organic substance. But the reality is that's not at all what these synthetic substances are. They're produced commercially by drug manufacturers, and they're produced illegally in clandestine laboratories for illicit markets worldwide. And we really see that it's scary sometimes how these drugs are manufactured. In fact, in some states, what we see is the synthetic marijuana or the substance actually is imported illegally from other countries because it's usually created external to the United States. It's imported in liquid form, and then it's sprayed on or infused onto other substances such as potpourri, and then it's sold as synthetic marijuana and ingested. And so one of the things about these synthetic drugs is that there's just such a variety of toxic chemicals that are used in the development of these drugs that makes the use of these even more dangerous than some of the other known substances that we're combating in our work. And so when they're produced clandestinely, they aim to mimic or enhance the effect of natural illicit drugs such as marijuana. But as we'll see as we progress, there's really no connection between these synthetic drugs and marijuana, which is produced organically and, may I also say, from a prevention standpoint, is not a safe drug in and of itself, but the dangers are multiplied exponentially when we look at these toxic chemicals that are infused on other substances. And according to the U.S. Customs and Border Protection, most of these synthetic drugs originate overseas, and they were first seen coming on the landscape in Ohio in 2008. And so spice is the one that really became sort of well known. Also, we'll look at some of the other ones, but really it initially was known as spice or K2. So these synthetic drugs are very, very challenging to regulate, and we'll see as we look at the brief history of these synthetic drugs why it became such a problem. The manufacturers often slightly modify the molecular structures of these drugs so that they can circumvent existing drug laws. And it really was a game of cat and mouse around 2012, which we'll look at, to try to expand and respond and enact drugs that actually incorporated all of the various chemical compounds of these drugs so that they were illegal. They're marketed as not for being for human consumption, and so they're marketed sometimes as bath salts or as potpourri, and of course, the intention is exclusively to be ingested to get a high, and so they're really marketing. It's not effective, and that we know that they're being marketed for abuse purposes. But by marketing them for not human consumption, they evade control of the FDA. And in terms of one of the things that make these so risky is the easy access, the low prices, and the misconception that they're natural and harmless have really contributed to the popularity or the notoriety of these synthetic drugs. And another thing is that it's changing now, but when they initially came on the landscape, they were not being effectively tested for with standard drug testing mechanisms. So someone who, for example, would be on probation that had to go through regular drug testing and was required to not use drugs or alcohol while on probation, in many cases could use these synthetic drugs and not be detected when they had to go through their regular drug testing. Now, again, this is all a moving target because we're still trying to respond to these molecular structures and include them in drug tests. But that sort of created this perfect storm of these synthetic drugs, as we'll explore moving forward. So the three types of synthetic drugs that we're really going to look at through this lens they're really divided into two categories, but the MDMA, which I'm sorry, I've been in this business for more than 25 years and I can't pronounce the full chemical compound of MDMA, but you can see it there in all its glory, that long word. But really there's two categories, but MDMA is integrated into the second, is the synthetic cannabinoids, such as the K2 and spice. They are designed to mimic the effect of THC, which is the primary psychoactive ingredient in marijuana. Now, having said that, that does not mean that one who ingests K2 or spice is going to get the same impact or effects of marijuana. In fact, very often it's more of a stimulant than it is sort of that marijuana mellows you out with the THC piece. So it really doesn't give the same sort of impact or effect on the body. And then there's the stimulants such as bath salts that are marketed as bath salts. And these contain chemical compounds that mimic the effects of cocaine, LSD, and methamphetamine. So often we'll hear some of these drugs referred to as the MDMA. So the bath salts are not MDMA, but they are stimulants. And we have often heard many, many extreme stories of humans feeling that they had extra strength, similar to what we used to hear in the 70s and 80s with LSD. It's the same kind of stimulant on the body, often real violent behavior and sort of out of control, that invincible feeling, which can be very, very dangerous. Flocka fits into this, and we'll talk a little bit more about flocka. Especially in Florida, the synthetic drugs have really been impacted. Flocka has sort of been that entry point of the one that many, many communities have done a lot of work to address over the last few years. One of the synthetic drugs that I will not be talking about today are the synthetic opioids, which are fentanyl and carfentanil, and are primarily produced in Asia. Now, as we get further into this presentation, I will explain why, when we're talking about primary prevention, there is a differentiation between the way that the synthetic drugs, such as the cannabinoids and the stimulants, present themselves for the onset of risky behaviors versus where the fentanyls and the carfentanyls fit. And so a little later on in the presentation, I'll give a further explanation of why, for the purposes of this discussion, we're not using looking through the lens of the synthetic opioids. However, when we're looking at the approaches to address any emerging trend, those apply no matter what the drug is that we're looking at. But I'll come back to that a little later in the presentation. So in terms of health specs, what we're seeing with the synthetic cannabinoids are, we see severe agitation and anxiety, sometimes nausea and vomiting, racing heartbeat, elevated blood pressure, hallucination, dilated pupils, and often suicidal or harmful thoughts and actions. So again, when we look at the health effects of the synthetic cannabinoids, the synthetic marijuana, we see that there are many impacts that really do not mimic the THC impact. And so it's really misleading to really say that this is a synthetic type of marijuana. It's really a completely different drug altogether and has a different impact on the body. Then there's those synthetic stimulants. Also lead to increased heart rate and blood pressure, chest pain, extreme paranoia. We also see extreme paranoia often with methamphetamine, again, another stimulant. We see hallucinations and delusions and a lot of violent behavior. These stimulants are extremely unpredictable in strength and in intensity, and so really when one ingests any of these synthetic drugs, you really don't know what you're taking or in how intense the impact will be. And then for the MDMA, that's often known as those club drugs like ecstasy, and that includes severe hypothermia and dehydration. There's really quickly a possibility of having long-term permanent impairment by using drugs like MDMA, the club drugs. We see the involuntary jaw clenching with these drugs, teeth grinding, high blood pressure. So with the MDMA, the ecstasies and those club drugs, you'll often see really when raves were really, really popular, and we still see it, that these club drugs, or these ecstasy and the MDMA is often taken in real social settings, and then people all dance all night long. They take an ecstasy and they dance all night long, and if you see pictures of it, you'll often see that they have a soother around their neck or a soother, and that's because putting in a baby soother will help with the involuntary jaw clenching. We've often heard, unfortunately, all too commonly with these club drugs and raves, deaths due to dehydration, because these drugs create dehydration and you're not aware of the fact that you're dehydrated. So the activity and the dancing all night long, and you're not stopping to hydrate your body because you're not able to read your body's signals, often has a fatal effect. And again, these chemicals can have, across any of these categories, these chemicals can have a lasting impairment even after one or very few uses. So these synthetic drugs are definitely a dangerous and emerging threat. So when we look at risk factors, what makes these emerging threats so risky? And we'll talk a little bit in a little while about why we're looking through the lens of youth. But when we're looking at prevention, we really are primarily looking at youth behaviors. Now, of course, we want to prevent high-risk behaviors across the lifespan, but we know that high-risk behaviors often begin in youth, and we know that the research is very clear that for most people that have a substance use disorder at some point in their lifespan, they began with high-risk behaviors in youth. So from a primary prevention standpoint, really we look at youth use behaviors as our starting point. And really, the DEA, the Drug Enforcement Administration, has indicated that the primary users of these synthetic drugs are youth. And generally, these products are cheap and are really accessible to teenagers either online or in gas stations, convenience stores, smoke shops, head shops, vape shops. So teenagers are able to access these drugs, and they're being marketed as things like herbal incense or bath salts, such as Spice, K2, Genie, you name it. There's a number of different brand names. Now, often I'll do an online search and just Google K2 or Spice, and websites are getting better. Some reputable websites are getting better, but commonly you would be able to find these things for sale on eBay or Amazon, but there's a lot of websites where youth are able to access these. But we're also seeing that they're extremely profitable for convenience stores and other stores who obviously know what the intended purpose of these herbal incenses are, and it's extremely profitable despite the fact that they promote and present a public health risk to those who use it. So again, it's about easy access, and so that's also for the stimulants. So when the stimulants, we see things like Ivory Wave. That's a photo of Ivory Wave. So you'll see it being sold and marketed as bath salts. It's usually a white or brown crystal-like powder. We also see things like Vanilla Sky, Lunar Wave, but again, they're not bath salts. They're not something that you add to your bubble bath. They are quite literally intended for human consumption to give an impact and to create a high. Flocka is closely linked to this category of drug. And so we know with the stimulants that we'll see reports of violent behavior, random acts of violent behavior, sometimes extremely harsh violent behavior because the people that are ingesting these drugs have hallucinations, have that sort of LSD kind of feeling of invincible hallucinations and paranoia, which often cultivates or accumulates into a violent behavior, often randomly to unsuspecting folks in the community. So looking at the easy access of the MDMA, now, these photos are actual photos taken from the local police department where I live in Wisconsin, and all of these are photographs of MDMA. Again, usually sold in nightclubs and at all-night dance parties, commonly known as raves. It comes in capsule form, but also can be a crystal powder. And so you'll see names like Scooby Snack, Snowball, Hug Drug, and often these also promote high sexuality and high sexual behaviors. And you'll see that in all of these photographs. These each were marketed in different ways because of the stamp that's put on the tablet. So the Scooby Snacks, for example, would have a stamp of Scooby-Doo on it. And so people will often look for one particular type of mDNA because it's being marketed. So that is just an example of what it may look like if it comes in pill form. So one of the things that I have tried to do in our quick 2 hours together today is to provide you with really good resources and obviously to link everything that I talk about with a strong evidence base and a strong science base. So you'll see that at the bottom of all of my slides are citations. And also on some of them, you'll see the citation like this one right on the slide itself. So when you get the slides, you'll be able to go to any of these websites. I wanted to highlight this one because this is a really, really good publication that comes from the DEA. And it's a really good quick reference guide to the different types of drugs of abuse. It'll describe the drug itself, the impact on the body, as well as some of the common risk factors for some of the drugs. Like, for example, as we just saw with these synthetic drugs, K2 and spice, and the stimulants, that easy access and marketing to youth is some of the big risk factors that the DEA sees that are of grave concern. So many of the slides that I use are embedded in the information that you will find in these credible resources. So no matter where you work on the continuum, whether you work in prevention, in treatment, or in the recovery community, these are just really good reference documents to sort of educate yourself on the different drugs that are being seen across the nation. And, you know, one of the things that I have learned working in every pocket of this country is just because one particular state is not seeing a particular drug at the time, borders in time really are transcended now. And so, you know, emerging threats move. And so if you hear about something you haven't seen in your community, it's always good to educate yourself on what it is, because chances are your community will see it at some point in the future. So part of the issue with synthetic drugs, and really it was at its height several years ago, and frankly I'm a little depressed that we're talking about this as an emerging threat, because we really thought that we had this one under control, but alas, it has started to rear its ugly head again. But this really, really was at its height a few years ago, and I'm going to show you a chart on the next slide of the number of calls, but poison control centers around the country received 7,779 calls in 2015, and then more than doubled that number in 2014. And this was for both the bath salts and for the synthetics. And then we started to see them decline. So let's take a look at what the slide shows. Now, this came from the Poison Control Center, and this is all national data. So as you can see, we earlier saw that the very first reported case was in Ohio of synthetic marijuana in 2008. So in 2011, we start to see that there's a really high number of cases of phone calls to the Poison Control Center. And so in 2011, there were almost 7,000 cases. 2012, it went down. 2013, it continued to go down. 2014, it went down. And as we see, there was some legislation that was enacted around that time, which really tried to eliminate the sale of these synthetic drugs, especially in convenience stores. However, we can't necessarily control the internet. But then we started to see a jump again in 2015. And so additional laws were enacted, and then we started to see it go down appreciably. So you can see in 2017, we started to see really a huge reduction in calls. However, in 2018, and those figures for 2018 are not final, then by the time 2018 came around, we didn't see a reduction continue, but rather we started to see a bit of a resurgence in the calls. And again, those are not the final numbers for 2018. So let's take a look at the state and federal response. So what were the responses at the state and federal level that really created those downturns in those calls to the Poison Control Center? Which, of course, is just one benchmark, but it's a good visual to see the use rates and how they were impacted by the state and federal responses. So the Controlled Substances Analog Enforcement Act of 1986 allows many synthetic drugs to be treated as controlled substances. So Schedule 1 or Schedule 2 substances. So they have, for Schedule 1, obviously they have no legitimate medical purpose, and they are illicit drugs. So we're looking under the Controlled Substances really Act through that lens. So that is for our illegal drugs as well as for any of the pharmaceutical drugs. In 2012, in response to this emerging threat, so remember, these chemical compounds were not necessarily included under the Controlled Substances Act, which created a huge problem for law enforcement because we were seeing that these drugs were extremely dangerous. We're seeing lots of calls to the Poison Control Center, but we don't have a really good basis under the Controlled Substances Act to enforce laws related to illegal drugs. So in 2012, the Synthetic Drug Abuse Prevention Act put up placement on 26 types of synthetic cannabinoids and stimulants into Schedule 1, which means they are the most restrictive. There is no legitimate medical purpose. So they infused that, they expanded the Controlled Substances Act to include those synthetic drugs. It also doubled the maximum period of time that the DEA can administratively schedule substances under its emergency scheduling authority from 18 to 36 months. And that's really important because although the bill permanently placed 26 types of synthetic drugs into the Synthetic Drug Abuse Prevention Act, so it was integrated into the Controlled Substances Act, as we've already discussed, these synthetic drugs were being changed slightly in their molecular structure so that they wouldn't fit into that 26 types of synthetics. So then law enforcement also were given some more latitude that they could restrict other drugs other than those 26 types through this emergency scheduling authority, and it gave them an expanded period of time, so 36. So as you can see, it's still a game of cat and mouse because there's so many chemical compounds that can just be changed a little bit so they don't fit within the confines of what the laws are, which is why we are seeing that we create laws, we see reductions, the chemical compounds change slightly, and then they are infused back in the market, and we're forced to then identify what these new chemical compounds are and then restrict them. So by 2016, though, at least 43 states have also taken state-level action to control one or more of the synthetic cannabinoids. And then prior to 2010, synthetic cannabinoids, it's important to note, were not controlled by any state. And in addition, at least 44 states have taken action to control one or more of the synthetic stimulants. So we're starting to see that we have both state laws and then the DEA Controlled Substances Act, which has been expanded to include these synthetics. And it really did start to make a pretty big impact. But also we needed to see, and we have seen, responses at the local level as well. Because again, all substance abuse really is local. And so while there are state and federal actions that can support the work, really the work of prevention is done in communities, as we'll explore in a little bit. This is a really interesting document, and I read it from cover to cover back when it first came out, and it's a really good document. If you're looking at the synthetic drug issue in your community or are interested in learning more about it, this was a briefing that was done from the Congressional Research Service, and it was provided to Congress in 2016. And it really does do a really incredible deep dive about the synthetic drugs, both the K2 and the spice and the MDMA, and talks about the challenges and the response, and is a really good document to learn more about what I quickly went through, which is, again, the sort of cat and mouse game of trying to create and respond to these changes in chemical compounds to try to get them off the market. So again, I'm pulling back this slide again because in 2016, when we looked at the laws, we started to see those dramatic decreases in use. And again, you know, I said earlier, I'm kind of, you know, disheartened that I'm talking about synthetic drugs in these categories as an emerging trend, because as someone who was working on the front lines for a long time, we started to see real declines and kind of, you know, sort of shook our hands and said, you know, all right, we've taken care of that emerging threat, you know, on to the next one. But again, it was not to be true. We're starting to see a resurgence, and it's really hitting every corner of the country. So this is from actually my own state of residence in Wisconsin, and this came out early in 2018. And it's actually interesting, no matter what state that you live in, to do a little bit of online research to see what other states are seeing. Now, again, I thought that we had this one covered. And then lo and behold, in 2018, we're starting to see a resurgence of the synthetic cannabinoids. And this time, what we were seeing in the Midwest, and certainly not just in Wisconsin, and it wasn't initially in Wisconsin. Initially, we were seeing this in Ohio and states like Illinois. But what we were seeing is these synthetic cannabinoids came back with a different chemical compound, and there was a particular strain that was actually laced with a type of rat poison. So what people were seeing was that they were having, in addition to the impact of the synthetic, so the high that they were seeking, they're also seeing really high rates of serious internal bleeding that was prompted by the fact that some of these chemical compounds were laced with rat poison. So, you know, as a person who works in prevention, I sometimes and understands the disease of substance use disorders, you know, sometimes I still shake my head and think, why would we put rat poison in these drugs? Certainly, there's no answer to that in my brain. But indeed, these drugs were creating really serious health consequences. So when we look through the lens of this being a substance that is marketed to youth and that is being used primarily to youth, just think about these chemical compounds which on one use can permanently impact the brain. They can create psychotic behavior. They can create suicidal tendencies, and they can also cause internal bleeding. So these synthetic drugs, again, are an extreme threat in our communities. This one is also interesting. This is the governor of Connecticut actually did a statement, did a press release because there was an outbreak of overdose cases in New Haven, Connecticut, and it was linked to K2, synthetic marijuana, and the spice. Now, we're seeing now overdoses. So one of the things that makes this resurgence so extreme is they have changed these drugs so drastically now that the impact on the body is even more extreme than what we saw sort of in the K2 and spice, the synthetic drugs, sort of generation number one. This new generation of drugs is causing overdose and is causing severe adverse impact to the body and in our communities. And this one actually was, and when you click on the link when you get the slides, this is a really interesting one. This is actually the headline, and this was from Fox San Antonio in October of this year. So these are real, new, and emerging threats. These are not from 2 years ago. These are all extremely recent. These are all 2018. And it says a new generation of synthetic drug peddling targeted toward teens. So as you can see, we saw the Midwest has a resurgence, and so the Department of Health Services put out a health warning. We saw on the Northeast that Connecticut, the governor's office declared that this is an emerging public health crisis that's causing overdose, trying to alert the public and communities. And then we saw in the Southwest, in San Antonio, that this is also hitting and impacting teens. Well, in Florida, we're also seeing it as well. So this is in Hillsborough County, that is also from 2018, that we have seen confirmed 2 cases of the synthetic spice that has, again, we're starting to see, it has rat poison. So we're seeing this new and emerging threat, the new synthetics, this generation, generation number 2 is coming on. And so in addition to those toxic chemicals, we're seeing that things like rat poison and overdoses are being are the impact now of this new generation. So these publications that I wanted to share in the slides, they're all recent. So a call to action, no matter what part of Florida that you are in, that you're calling from today, I would say this would be something that I would take a look at and see if locally you've seen this. Again, when we talk about access, youth have cars, online access is an issue. And so if it's in one part of the state or one part of a country, it starts to blanket the country. And so it's really, really important to know whether or not these drugs or chemicals are in your part of the community. So at that point, I'm just going to stop for a moment, and I'm going to ask any folks to chat in the chat box and to just share with me, is this anything that you're seeing in the community, the K2 or Spice? Is it anything that you've heard of, or anything that you're seeing locally? And I'm just going to give a minute because I would like to have folks respond in the chat box. And if you haven't seen it, just chat in, respond in no. And if you have seen it, I'd love to just know that too. So I'll just give a second for folks to chat in the chat box if these types of synthetics are anything that you've seen or anything that you have not seen. So I hear someone say that they're in a rural part of Florida, and so and I think that rural or urban, the drugs find their way. But yes, maybe in the rural areas they're not as accessible. Although I don't know if I would take that for granted. One person now, again, only Diane and I can see the chat, is someone said, when I lived in Naples, Florida, it was huge with the adolescents. And some things that we're not seeing at all. And again, in Florida, you guys were really pummeled with Flocka a few years ago, and many, many communities have done extreme and very effective responses to get it off the street. And again, it's coming back in a different form, not necessarily Flocka. Someone says, I've heard of K2 and Spice. But I believe that we had discontinued. Yes, it's still being used and it's coming back. Someone says they haven't seen it in the stores in our area. See, this is the thing. We thought we had this one handled. And so, restricting it in convenience stores and vape shops and the head shops where, paraphernalia is sold, we thought we had this handled. Remember, these headlines that I'm showing you, are recent. It's on its way back, folks. And so what we thought that we had handled is coming back, and it's coming back in different ways. So I'm seeing some folks that are saying that they're seeing it less than in previous years. You do see it with adults with substance abuse clients. Some folks are saying it. They are seeing it in stores. Yeah, again, it's coming back. And so this is one of the things sort of to keep your eye out. And for those of you who are sort of screaming from the mountaintops at your desk saying, why is Dorothy not talking about the synthetic opioids? I'll get to that, because what was important to understand with this threat is these are often being marketed to youth. So this is, in some cases, one of the first substances that youth may experiment with, and not that any substance use among youth is safe, but this is an exceptionally dangerous one because of those chemical compounds. So sort of a warning is, make sure that we know what the lay of the land is. And, sometimes I feel like we're sort of squishing one end of a balloon. You push on one end of the balloon and the air goes up in the other end, or sort of that whack-a-mole. We get one drug done and then we have to connect on another one. And it feels like, it's Groundhog Day all over again with these particular synthetics, but in some ways it is. So one of the questions that was really good here is I'm wondering if there's a correlation between the rise in synthetics and the crackdown on pill mills that occurred earlier in this decade. And I think the answer to that is a resounding yes. And let me tell you, it was interesting. I was doing a series of prevention trainings in Florida in June of 2018, so just last year. And Florida has done, in fact, you're considered to be a best practice. When I'm on the national level, I often use Florida as a case of best practice with some of the proactive and comprehensive laws that were passed to really reduce and prevent the impact of the epidemic of prescriptions, especially the opioids. So we've seen a reduction in access. And as a sidebar, one of the communities that I was working with when I was in, I think I was just outside Miami in Fort Lauderdale, and so there was a group of folks from that region, and somebody in that community was saying that while the pill mills are gone, that there were physicians that are now flying in, setting up shop temporarily for a week at a time, and then selling their, prescribing the opioids out of sort of temporary offices. But yes, what we've seen nationally is when folks have been accustomed or have an opioid use disorder or a substance use disorder, and that access is gone, that the substance use disorder is not gone. So people are switching drugs. In many, many parts of the nation, we're starting to see that the heroin and the opioids, both the legal and the illegal opioids, are on the decline. Still high rates of use, certainly, but they're on the decline. But what we're seeing is methamphetamine, crystal meth, is blanketing, and we can see it coming across the country. It's still sort of in the north, but it's moving throughout the country. But what we're seeing is people with opioid use disorder, they are often on medicated assisted treatment in some cases, and then they're using methamphetamine, which is a completely different impact on the body, a completely different sort of high, but they're transferring one drug to another, and absolutely that's what we're seeing is, especially with adults with substance use disorder, moving back into this K2 and spice, it's resurging, it's coming back. And so if they're in drug treatment courts, or if they're in treatment, or they're undergoing drug treatment and drug testing, often these types of drugs with their new chemical compounds are escaping the drug testing. And so one question is, and I want to take a little break in just a few minutes, is I'm curious your thoughts, any news on Kratom. They have kava lounges around here which have Kratom. The DEA is considering scheduling it, and it's widely available. It is in one of those categories of the synthetics, yes, and it should be scheduling. Lori, I'm glad that your audio is back. I don't know why it kicked out, but yes, it should be scheduled, and it has really extreme impacts on the body. And what we start to see with this is sort of trends based on region, and there's some really scary trends with some of those drugs. But yes, my thought is it should be scheduled, and it really is one of those categories of drugs that really has an adverse effect. Some of these really unpredictable effects on the body. Again, there's no safe drug to use, but it's really important for us to understand that this is a whole new generation of synthetic drugs. So now that we've talked about the drug itself, I want to spend some time talking about how communities can respond to this emerging trend. And I think this is a really good break point. We normally take a break right at the top of the hour, but this feels like a really sort of good natural point. So Diane, why don't we do our break right now, and then we can continue on with the second half. We're just about perfectly timed for 1 hour into the next hour.
I agree with you, Dorothy. Let's go ahead and take a 5-minute break at this time, and we'll start sharp at 11 o'clock. Thank you. Hello, everyone. Welcome back to today's webinar. Dorothy, if you're ready, I'll turn the presentation back over to you.
Awesome. Thank you, everyone, so much. And thank you for giving me your feedback on what you're seeing and what you're not seeing in terms of the emerging trends in synthetics. So I'm going to switch gears a little bit now and talk about, so how do we respond to this emerging trend? And I can't do this last half without sort of just founding myself into my perspective as someone who works on this prevention all over the country and under a number of different sort of contracts, is that no matter what the substance is that we're looking at, the Substance Abuse and Mental Health Services Administration, SAMHSA, really says that the approach is going to be the same, and that is that we use the Strategic Prevention Framework, the SPIF or SPIF, to address whatever the emerging trend is. And so that's why it really is the drug is really secondary to the approach that one uses to address it. Now, the Strategic Prevention Framework you may be familiar with, or if you've gotten any funds from SAMHSA to do prevention, it probably is written somewhere into the project. We see that there's a SPIF RX grant that is often in states. That's the Strategic Prevention Framework RX grant. We see the SPIF PFS, the Strategic Prevention Framework Partnership for Success grant. We also see that if any communities are looking to procure funding through the Drug-Free Community Support Program, which is a partnership between SAMHSA and the Office of National Drug Control Policy, that SPIF is built right into that application. So the SPIF is the best practice related to approaching prevention at the local level. I also just want to say SPIF can also be known as sort of collective impact. You may work with public health or be a part of public health and be involved in a community health improvement planning process, or you also may be affiliated with your local United Way or community foundation and doing something called results-based accountability. One of the things that I often say is they're all Coke and Pepsi. They're all different ways of looking at the same kind of systematic process to gather data, to build your capacity, to develop a plan and implement the plan and evaluate it. So the Strategic Prevention Framework is a methodology or framework. So I'm going to work through it as we look at through the lens of an emerging issue. Again, this only becomes really helpful for me when I hear from you. So I'm going to try to continue to monitor the Q&A box and answer any questions as we go through this piece. So there are really a couple of sort of fundamental pieces that the Strategic Prevention Framework is based upon. So first of all, it's collective impact, which means that to be really impactful in our prevention work, we have to go beyond programs. You know, I'm on the school board in my community, and one of the things that I have learned working with so many communities, but also through my perspective being on the Board of Education, is that sometimes we make schools feel like they're responsible for solving, the problems that exist in the community that are impacting youth. And certainly schools have a role to play, but so do parents, so do retailers, so do law enforcement, so does healthcare, so does prevention, so does public health. And so the SPIF really reflects that work collectively is how we're going to make an impact. And the other fundamental concept that the Strategic Prevention Framework is based upon is best explained by this little guy, this frog in the pond. So if you were in face-to-face with me right now, what I would ask is, if you have a frog pond in your backyard and the frogs start changing color and they're not green anymore and they're not hopping and they look really sickly, what would we do? Now, if one was heartless, they'd say, kill the frogs and get new ones. But really what we want to do is we want to change the water. When we see that the frogs are unhealthy, we need to test the water. And so the strategic prevention framework is really built upon the public health approach, that we need to look at strategies that are going to impact the individual frogs, and we're also going to have to look at how do we change the pond. And that's really PSE, policies, systems, and environmental changes. And so the reason that SAMHSA promotes the use and requires the use of the strategic prevention framework is because we recognize the science says we need to have a balanced approach of programs and of environmental change. For those of you that work on the treatment side of things, this is exceptionally clear, isn't it? We can get patients or clients that get into treatment and they move into recovery, and they can be in a really good place. But if we don't have enough sober housing and a supportive environment and they go back into those old environments, what's going to happen? Well, we know that the chance of relapse is going to be much higher than if they're in an environment where they don't have access to old habits and old peer groups and old ways of acting and behaving. So from a prevention standpoint, the same is true. We need to make sure that we've got programs that target individuals, but that we also need to make sure, especially looking through the lens of synthetic drugs, that youth can't get their hands on it, especially since we saw from that headline in San Antonio that they're being marketed to teens. Well, so part of it is we want to make sure that we are providing programs to teens, but we're also needing to make sure that in the pond, teens aren't able to get the substance, nor is anyone else. So those are the two fundamental principles, the lens through which we look at the strategic prevention framework. So it really is a questions-driven approach. So first of all, we assess needs. What's the problem, and how can I learn more? And we'll spend some time on that for the rest of the call. How do we build capacity? What do I have to work with? Who are the key stakeholders related to this problem? And we'll spend a little bit of time touching that too. So it's important to note that the key stakeholders that you have at the table may be the same regardless of some drugs, but then there's also going to be new people that are engaged. You're going to have pharmacists playing a different role when you're looking at prescription medications than you are with maybe engaging retailers when you're talking about synthetic marijuana, because there's different roles for the retailers for the synthetics, which is where sometimes youth are getting them, versus for pharmacists with what they're seeing with the prescription medications. And that's an integral part of this as well. Then we develop and implement and evaluate an action plan. And I'll go through a couple of sample action plans that reflect best practice for the strategic prevention framework. And then we also want to make sure that we are being culturally competent, which means inclusive of the people in our environment. So are we involving, are we looking through the lens of health disparities? Are we involving the people that are being impacted most by the problem? And then are we sustaining the work that we're doing so that we will sustain the outcomes? And really when I talk about sustainability and I think about all of the laws and the regulations that have been enacted in response to the synthetics, we kind of thought that we were going to sustain it, but this is a different beast in that we haven't been able to. I see a question here and I'm going to read it. Please explain that while mollies have been often described as being pure MDMA, then in reality, mollies have been actually the synthetic stimulant cathinones. In Florida, following different cathinones sold as molly today is mostly and I can't say it, S-pentalone. Well, my response to you is simply this. Any illicit drug, we don't know what is in. And I don't know, with the Molly situation, I mean, we see a lot of Molly really reflected in sort of pop culture, in music, and it's lowering the perception of risk. The reality, though, is that any of these illicit drugs can have any of these chemical compounds. And the notion that those club drugs or the Molly or the MDMA is just a drug that you can, take and party all night long couldn't be any further from the truth, is that anytime anyone ingests an illicit drug, you don't know what you're getting. And the reality is that a lot of these drugs are being manufactured outside of the country, and when they're imported, drug manufacturers are putting whatever chemical compounds that they find marketable or is going to give them the edge. Earlier in that slide when I showed you the 3 different types of, yes, what was marketed as pure MDMA, but they all had different labels. Remember that this is also a supply and demand market as well. So people make, these drug manufacturers, they want you to ask for, Scooby snacks specifically. So often they change the chemical compound to give a more intense feeling of euphoria or even heightened sense of sexuality so that they have a sort of a competitive edge over the other types of Molly or MDMA that is sold. And so that really explains for why there's different chemical compounds. It also means that from a sort of a local perspective is we need to make sure that we're working with law enforcement and that we know what the chemical compounds are within our communities, because it's going to really help us in identifying and responding and developing a plan. So really good question on that, really good question. So keep them coming. So this is where I'm going to speak a little bit more about the opioids piece, is when I start to talk about what is the definition of prevention. And so let me say, we talk about overdose death prevention. That's definitely prevention. It's prevention of death. We also want to see prevention of a substance use disorder. So we want to do an intervention when there's high-risk behaviors before there's a diagnosis. So that's prevention of a substance use disorder or prevention of a diagnosis. But the Institute of Medicine's continuum of care has a very distinct definition of what we call prevention. Now, sometimes we talk about primary, secondary, and tertiary prevention. Really, that's what we're talking about is primary prevention. So you may be familiar with this diagram. It's the Institute of Medicine's continuum of care. And when I'm working on the opioid issue or underage drinking or vaping or synthetic drugs, I always bring this diagram as I bring agencies and organizations together because it's a really good illustration of where we all fit in working on these issues. And so I'm not going to spend a lot of time on it, but the Institute of Medicine's continuum of care, you can see on the far left, you'll see promotion, and you also see it along the bottom. Now, promotion is not like promotion of like public awareness. It's more of promotion of a balanced and healthy life. So we can see that it goes all along the bottom. So even if you're on the treatment side, there's still promotion. Really, the way I describe it, sort of in sort of layman's terms, is it's promotion of a balanced and healthy life. So, for example, we don't just want someone to be clean and sober, but we want them to have a quality of life in their sobriety and their recovery. And so it's an integral part of wherever we work that we want people to have a balanced, healthy life, the promotion of a balanced and healthy life. And then we see there's 3 definitions of prevention: universal, selective, and indicated. And if we had more time, I'd go into those. But if you do any state reporting, you may see that you have to report your interventions or the things that you do by universal, selected, or indicated, and subcategories of those. And then you're going to see a 90-degree angle, and then we see treatment and maintenance. So the question and the most important piece when we're looking through the prevention lens is what is that 90-degree angle that separates prevention from treatment? That 90-degree angle is diagnosis. So the diagnosis is what separates the prevention from the treatment. So that can also be a self-diagnosis. So why is that an important line, and why is this an important diagram in defining prevention? Well, when we're looking through the prevention lens, what we're talking about is behaviors and substances of use prior to the onset of a substance use disorder. So think back to that headline that we see that the K2 and Spice, this new generation, is being marketed to teens. That's usually happening prior to the onset of a substance use disorder. Now, certainly we see adolescents who have a substance use disorder that make that line between indicated and treatment of diagnosis. But that's where the substance use is really starting primarily. And we know that the vast majority of people that have substance use disorders across the lifetime had an early initiation of, and what we tend to see is alcohol, tobacco, marijuana. We also see K2 and Spice or prescription drugs. But it's those substances that come prior to the onset of a substance use disorder. So now let's look through the lens of those synthetic opioids. The carfentanil, which really its initial uses was as an elephant tranquilizer, and the fentanyl, which is an extremely high potency painkiller, which is often used at end-of-life care. There's the sublingual, which is a slow release that goes under the tongue, or a fentanyl patch, often used in institutional settings. So that's what the original intent of both the fentanyl and the carfentanil is. But we are now seeing a massive influx of fentanyl and carfentanil into our communities. Now, I'm talking micrograms can actually prompt an overdose. But where we're really seeing the carfentanil and the fentanyl is post-diagnosis. Really, what we're seeing is in heroin users, we are seeing that the fentanyl and carfentanil is added to the illicit heroin. So really, the interventions related to the synthetic opioids come farther down the continuum of care, because in all of the communities that I've worked with, only maybe one or two have I heard that youth are going zero to heroin. Heroin is sort of one of those drugs that happens usually when we're talking about population level use, right? Statistically significant numbers. It's really happening post-diagnosis. It's not one of those drugs of initiation. And so it really happens on a different end of the continuum. So that's why, for the purposes of looking at it pre-diagnosis through the prevention lens, we're differentiating the fact that these synthetic K2s and marijuanas and cathinones are being marketed to teens versus the synthetic cathinones and fentanyls, which are part of an additive for heroin, which is really sort of the deep end of the pool for folks with advanced substance use disorders, especially those who make the transition from prescription drugs into the illicit opioids. So that's the differentiation related to the different types of synthetics. I certainly invite comments or thoughts on that in the Q&A, but that's the lens that I look at when I'm looking at the Institute of Medicine's continuum of care and how to differentiate those different substances, because they're really the where we are in the intervention level is going to be different, because they're really marketed to two different audiences. So again, I don't see any Q&A comments on that, but certainly invite them. So really, we look back at the foundation of the strategic prevention framework is data, what is the data telling us? I've shared some national data with you, and then we're going to spend a little bit of time looking at other data sets. And that's in keeping line with the strategic prevention framework, is starting with the very top bubble there in red, which is assessment, which is where the cycle begins. So when we're looking at assessment, we're really looking at answering the following questions. What is the problem? What is the drug that's being used? What are the drugs of initiation? And we don't use the term gateway drugs, but what are the initial drugs that people are using? When we're talking about, and for those folks that work in treatment, you know this better than me because I'm not a substance abuse counselor, but we see that folks start out with high-risk behaviors with one particular substance because they're impulsive. It's an impulsive behavior. As the substance use disorder progresses, or sort of the onset happens and then it progresses, is those impulsive behaviors become compulsive behaviors, and then we can't stop the behavior. But very often the substance that is the drug of initiation is not sort of the drug where folks with advanced substance use disorder end. Even with alcohol, we often see that the substance of initiation with youth, for example, may be early onset use of tobacco at 9 or 10, and then progressing into alcohol or to marijuana or to prescription drugs. But what are those drugs of initiation? From a prevention standpoint, we want to stop that first substance use because we want to mitigate the potential for a substance use disorder by delaying the age of onset of whatever those drugs of initiation are. What are the consequences? So hospitalization data, arrest data, expulsions or suspensions at the schools. What are those risk factors? Where are they being obtained? And why are they experimenting? Is it undiagnosed mental health issues? Is it stress? Is it academic performance? What are those risk factors? And then the demographics, who is using? What populations are being impacted most? And then what is happening locally? So whether you're in a rural area or whether you're in an urban area, what is happening in your defined geography related to where kids are getting it, where it's being used, who's using it? Is it not kids that are using it? Is it folks that have other substance use disorders that are part of a drug treatment corridor and treatment are using another substance because then they, it won't be detected on drug tests? So what's happening in our own community? And to do this, we use a strategic mix of both quantitative, which is numbers, and qualitative stories. And it's really important because the quantitative data tells us the scope, the what is happening, the rates of use, the numbers of use, the magnitude. We can look at the consequences by looking at the rates of drug driving arrests. We can look at the rates of numbers of calls to the Poison Control Center. Those are good numbers to give us magnitude and scope and impact, but it's not going to tell us the whys. That's what the qualitative data is for. So we really need a strategic mix of both qualitative and quantitative as we're doing our diagnosis to look at what are those emerging threats and what is happening here. So where might we look in your community to find data on synthetic drugs? And I'm just going to give just a second in case anybody wants to type anything in. So if you're going to look at data on the synthetics, what might be some of the information that you would look at in your community? I'll give you just 30 seconds, not even that, and then I'll share. But just in case anybody wants to type in the top, I'll just take a quick pause. All right, so I'm not seeing anybody type anything into the chat box. Oh, medical examiner, I am. Good. Yes, medical examiner. That would be a really good data set, especially when we're looking at those synthetic fentanyl and carfentanil. But yes, what is the medical examiner seeing? Hospital, yes. ER records, death toxicity, yes. Police reports, available at the county level, absolutely. Any of those. Police, yes, police are going to be your early warning system. Just a side note, I think of all the work that I've done over all of these years, what I've learned most, even aside from my degrees related to substance use, is what do the local law enforcement know? They know it, they see it, and you're definitely, so all of those, yes, that's where we're going to find data on synthetic drugs. And I'm going to come back to that and build on that too, so keep the DEA, yes, crime lab data. So, Jim, I'm going to just park on that. Crime lab data is really, really effective, good data to see what is emerging. Just a quick sidebar. When I was working on the heroin issue in some states, what we would see is, and I'm sure I wasn't watching the data in Florida, but I'm sure it would have been the same because you were really ground zero in many contexts for the pill epidemic. You were one of the sort of ground zero states. So what we were seeing as states started to get a handle on reducing access and availability of the prescription medications. Remember, this is a supply and demand business. So what we were seeing was really high levels of cocaine coming in with high levels of purity and cheap price. So what that meant was that the illegal drug cartels and the folks selling the drugs were trying to establish a user base. So by monitoring crime lab data and monitoring the purity level of the heroin, you could see that that was an area that was being targeted to establish a user base. And then monitoring crime lab data over time, we could see two things, that the purity level was going down, and then we were hearing from law enforcement that the price was going up. So what does that mean? That means we have an established heroin user base in that particular community. So regardless of what the issue is you're looking at, those crime lab submission data sets are extremely important for us to use as an early warning system for what's happening in our community. And I just want to spend, and I've talked about this, sort of infused it throughout the presentation, but why do we focus on youth? And certainly, substance use disorders can happen at any point across the lifespan. In fact, we're seeing with older adults the, sort of later stage life onset of opioid use disorder with chronic pain and just the fact that the body changes and over time. And so a prescription for chronic pain may turn into a dependency. We're also seeing sort of polydrug use or polysubstance use with older adults that have unintended impacts based on consumption of alcohol and having a prescription for pain medications. So the onset of a substance use disorder can happen at any point across the lifespan. But when we look sort of at population level trends, by and large, substance use disorder begins with high-risk youth use. And we know that someone who starts to use alcohol, for example, at 14 years old is, I've seen I've heard is as high as 6 times more likely to develop a substance use disorder across the lifespan. So when we're talking about primary prevention, which is pre-diagnosis, we're usually talking about or have an emphasis on youth use. A comment here is hopefully preliminary numbers for 2018 from the state attorney. Overdose deaths are down 42% in Palm Beach County. Hopefully we can identify and build as what's working. Limits on prescribing, expansion of MAT, Narcan, availability and prevention. Yes, yes, and yes. And it's really important to note that expanding access to medicated assisted treatment, I mean, that's got such a strong evidence base. Reducing stigma, so that, because we often see that there are prescribers that are waivered to prescribe Suboxone, for example, but don't want those kinds of people in their clinics, so they're waivered, but they're not prescribing. We know that expanding access to MAT, we know that expansion of Narcan will have an impact on overdose deaths. And we know that limiting prescriptions is so impactful on mitigating the impact of the prescription drugs. And you know what? It's also about prevention. Absolutely. It's also about sort of all of those pieces are sort of post-diagnosis, but the prevention piece is really important as well. Yeah, we all fit together, and it's fantastic to see that we're seeing statistically significant drops in overdose deaths. Let me just also say that's one of the reasons that I constantly use Florida. Kentucky is also another one of sharp reductions in overdose deaths. It's because of some of the really great laws that have been passed related to prescription medications that we're seeing it. But we all fit together, and prevention is a critical component because, remember, we're not just trying to eliminate the impact of overdose death. I've seen anywhere between 44,000 and 64,000 opioid-related overdose deaths last year. But however, the CDC also says that 88,000 people died from the result of the impact of alcohol use. So we want to also prevent the onset of any substance use disorder, which is where prevention comes in, so important. So assessment, and we're going to go through this pretty quickly. But so the Florida Youth Substance Abuse Survey, and we're going to spend a little bit of time just looking at that data, and I'm sure it's not new data to any of you, but I want to look at it through the lens of how we analyze it, just have a quick discussion. Law enforcement data, so arrests for possession by type of drug, and if you can get that by age category, that's also going to tell you who's using what type of drug. An environmental scan by walking through your community and just finding out where those convenience stores are, those vape shops are, and what you're able to buy within those can be a really important piece. An online scan. What websites are selling and what are they selling and how easy is it to order? It was disheartening but interesting. For example, I was in North Dakota a couple of weeks ago, and one of the state employees pulled up on Amazon a hoodie that you can buy. I think it was $49.99. So if you can buy it in North Dakota online, you can buy it online in Florida or anywhere, that had actual like vape, the jewel in the drawstrings of the hoodie. So I was amazed. So for $49.99, a youth can say, "Mom, can you buy me that hoodie?" And they could actually then have vape actually built into their clothing. So that's all the kind of thing that you need to look at when you're looking at what's happening in your community. Is what's happening online, what is it available and where, and then also that qualitative piece, focus groups, key informant interviews. So what is the Postal Service seeing? Is there a particular website, or what information do they have? Is there high risk? What's on their radar? Law enforcement, as we talked about, youth, school administration. The vice principal or the assistant principal is usually the one that is designated to work on issues of discipline. What is the superintendent seeing in terms of trends related to expulsions and suspensions? The recovery community. When did they start using and what did they start using with? What is sort of the issue in the community from their perspective? And then who else? So finding out who those key stakeholders are in your community and having some conversations that's going to give you more than one data set on what you're seeing. And, it's interesting because we may not see on our Florida Youth Survey much about synthetic drugs. It may mean that the question isn't being asked, or it may mean that it hasn't been reported by youth yet, but there are other indicators that it's coming based on, law enforcement and the environmental scan that it's accessible. So it really is a strategic mix of looking at all of these different data sources to try to create a picture of what's happening in your community. And so looking through the lens of your survey, are the questions related to the emerging trend that you're interested in finding out about, are they asked on your survey? And what are the highest rates of use? What are the age range that we see? And as we look at this data, we're going to start to be able to see some of these questions answered as we look at the survey data. And we usually see a sharp increase at some point in the use of the substance. And so that's really important as well to drive our work. So we're going to spend a little bit of time now, not much, talking about the Florida Youth Survey. I just have to say, again, you're very fortunate in this state to have a really good state-level report like this. In some states, it's not nearly as comprehensive. And so this is a really good instrument that can be used locally and at the state level to give you an idea of what the trends are. So this is a good data source. Again, we talk about we want to have more than one data source, but this one is a really important one when we're talking about prevention. So this slide, this is the lifetime prevalence of alcohol, tobacco, and other drug use for 2018. So let's unpack this a minute. I'm going to give you a second. I'm sure most of you, if not all of you, have seen this before. But I want to just pause here so that folks can have a minute just to look at the data. And then let's just spend a second analyzing what this slide is really telling us. So I'll give you just a second to look at it. All right. So what we really see here, and I certainly invite anybody to put comments in the Q&A, what we really see here is that alcohol is our biggest substance. And that is really no surprise. We also see that there's a really big jump between 6th grade and 7th grade from 12%, from 12% for alcohol up to 20% in 7th grade. And look, by the time we're in 10th and 11th grade, we're at almost half of the youth are reporting lifetime use of alcohol. So that can really help us by identifying where we need to intervene so that we can prevent the onset of use. Certainly, we want to make sure that we're doing effective prevention messages prior to 6th grade because, even a little bit more than 1 in 10, that's very dangerous use. That's childhood drinking, really. And so we want to make sure that we do everything we can to reduce and prevent that. Cigarettes is interesting. We know that the use of cigarettes are on the decline, but then take a look at vape and e-cigarettes. And so look at that. For example, in 11th grade, we see that 15.5% of 11th graders are reporting that they're using tobacco. And again, our tobacco numbers nationally as well as in most states coming down. But look at e-cigs. So it's more than double the rate of use for the e-cigarettes that we're seeing. So, and this really is matching what we're seeing on the national level is e-cigarettes and vape. They're being marketed, often flavored, which even though the tobacco industry is saying, especially like Juul is saying that it's not being marketed to youth. I mean, who really wants to ingest bubblegum flavored or cherry flavored vape? And even though the Centers for Disease Control and the FDA have recommended restrictions on flavored Juul, it's still very, very much available, especially online. So that's a really important thing to see. The other piece of it is what we're seeing is that vape paraphernalia is often, and we're seeing this, they're using it for the synthetics. It's sort of the delivery mechanism. The e-cigarettes can be the delivery mechanism for other drugs, marijuana, synthetic marijuana. We've seen methamphetamines. We've seen other drugs that are actually used through the e-cigarette mechanism. So that's a real danger sign. Let's look at the synthetic marijuana. We're seeing that nobody in middle school, so 6th, 7th, and 8th, but we're seeing that there's something happening between 8th grade and the freshman year that we're seeing that it's starting to use. Now, it is a low percentage, only 3.2%, and it goes all the way up to 4.2%. So by 12th grade, so compare that to alcohol, and certainly the magnitude of alcohol is a lot more significant than the magnitude of use of synthetic marijuana. However, there's no safe substance, certainly. But remember that some of these new generations of synthetics are being marketed to teens, and they're extremely accessible, and they have things like rat poison. So the impact of that on that 4.2% can be extremely detrimental even after the first use. So what is the primary method of ingesting bath salts? Is it orally or nasally? I have seen it orally. It is often smoked. It can be snorted. It can be injected. And where we're seeing it really, really, when we see those extreme stories on the news, and unfortunately Florida's had quite a few of them, but there were some stories, I'm hesitating here because there were some really bad stories of people, biting and doing really violent behavior. Primarily, that is bath salts, that is the stimulants, and they are taken intravenously. And so there's multiple sort of delivery mechanisms for these drugs where they get, as we know, intravenous drug use is going to give you that most intense feeling of whatever the drug is. So we're seeing sort of, you name it, it's being used. Good question. So let's take a quick look at the Florida Substance Abuse Survey. And again, this is not new data to you. I'm sure all seen it. I just want to sort of ground us in it, and again, encourage more questions as well as we are in the home stretch here, so that we can answer any questions you have. And if there's anything that you maybe doesn't gel with you with what I've said, I invite certainly feedback on that too, because one of the challenges of a webinar is I don't get to see the audience. So I've got a question. When vapes and e-cigs are not being used as delivery for other drugs or with marijuana, when they're used in place of cigarettes by adults, are there any reasons we should be concerned? So when they're used by adults, a couple of thoughts on that. So if they're really being used as, I guess, what is being marketed as their intended purpose. So we know that e-cigarettes and vape has been marketed to adults as a safer alternative to traditional tobacco. And so really, the tobacco industry will say, well, really, it's a cessation tool, that, you know, it's sort of one of those things where you're going to step down. So in that context, if an adult is using it as a tool or a cessation aid, then really there's no cause for concern. However, what we are seeing is really the message that's being heard with the e-cigarettes is not the way I described it, that it's a safer alternative to traditional tobacco, but rather what's really being heard is it's a safe alternative to tobacco. And so that's part of the reason why we've seen such epidemic proportions, and it has reached epidemic levels of youth, is that they have a low perception of risk. But we also see that there are some adults that have a low perception of risk, so they actually go from zero tobacco use to e-cigarettes because they think that it's safe, and that creates or reinforces, if their children are seeing, their teenagers are seeing them use e-cigarettes, that's going to lower the perception of risk of youth even further, and it's going to create a community norm that says that it's okay or safe to use these e-cigarettes. So that's really the danger or the risk in these e-cigarettes, is the perception that they're safer. But when used as a cessation tool, then they are apparently they're supposed to be effective. So let's take a look, and I hope that answered your question. Maybe I'm jumping ahead. What are the colors on the map indicated of? They are, and we're not going to go into that. When you look at that specifically, that's levels of use. So when you go after this webinar and look at the map, you're going to be able to see levels of use. That's showing rates of use, so you'll be able to see that. So, but let's just take a little look at what we're seeing in Florida. So the purple line is the Monitoring the Future survey, which is a national instrument, and then the FYSAS is your Florida Youth Survey. And so what we're seeing is with alcohol, so past 30-day use, we're starting to see, or we're seeing pretty steady declines in underage drinking, both at the national level, but also at the state level. And it's interesting to see, if you look at the 2016-2017 data from Monitoring the Future, they've sort of bottomed out. In Florida, you're going to surpass, or have surpassed, and will continue to surpass, I would suspect, the rates of use at the national level, which means that your prevention efforts that have been ongoing and so hard-won are working in Florida. When we look at binge drinking, however, we do see that that in high school and middle school, we're still seeing so binge drinking is not just past lifetime use, but it's high-risk use. So that's really concerning. We're also seeing that there's a huge jump between middle school binge drinking and high school binge drinking, which can help us design the age of our interventions. In cigarettes, again, this reflects that first chart that we saw, that we are seeing pretty consistent declines, both at the state level, and you're below the state numbers, which is great, and at the national level. This question normally does not include e-cigarettes, though. So when we're looking at e-cigarettes, we're actually seeing a different situation altogether, because we're still seeing that rise at the state level, at the national level. Just some of the highlights that we're seeing in terms of emerging trends in drug use is, compared to alcohol, cigarettes, and vaping and marijuana, other illicit drug use is very low. So that's great. That means that we have very few students that are using any of the drugs that are Schedule 1. The rates for other illicit drugs have declined over time. This is my hats off to all of the folks that are working in prevention in every pocket of the state. And the reductions are not as large as for alcohol and cigarettes. And that's interesting because, I would surmise, because we've got such magnitude of alcohol and tobacco use and such small percentage of use of those illicit drugs that it's easier for us to have and to pass policy systems and environmental change that's going to have a broader impact on those drugs and substances that have legal channels to access them versus the illicit or the illegal drug market. And I just want to, we're going to look through the lens again of those synthetic drugs. So let's look at the prevalence of past 30-day use. Now, again, I pulled these off of the 2018 FYSAS survey, so you'll be able to pull the whole report if you haven't seen it. So I just pulled a couple. So let's go way over to the left, and we're going to see that obviously our highest rates of use are alcohol, followed by vape, so the e-cigarette, which is new on the landscape. Then we're going to see marijuana and hash, and then we're going to see binge drinking. So those are the ones that are really cause for concern. I'll tell you some of the other ones that I see. And again, I'm watching the Q&A, so if you've got any thoughts or comments on this, I certainly invite it. So then look at the inhalants. So that to me is really, really shocking too. That tells me that we've got an issue that some states, some communities don't see inhalant use. Now it's only 2.8, but that, what are they inhaling? Are they using a dust off? That can cause permanent, irreparable brain damage on first use. So really, we're looking at those emerging threats that we need to use even more strategic responses to. Let's also keep looking down. We see over-the-counter drugs, cigarettes, but cigarettes see a lot less use, 1.2% versus 6.4%. Then let's keep going down the list. Okay, so then we're starting to see, and that's what the other slide before that said, is really the rates of illicit drug use are very, very small, so very small heroin use. But then let's look back at those prescription pain relievers. So I'm going to say RX depressants and pain relievers and even over-the-counter drugs, I would almost combine those when I'm looking at the risk for the opioid issue, because very often teens will start with Ritalin, with Adderall, with Xanax, and then they'll progress into the painkillers. So I would say any prescription drug misuse over the past 30 days is an indicator of high risk for onset of the opioid use disorder, as well as over-the-counter drugs, which we know that can be easily leads into other medication abuse. But see, we also see the methamphetamine, LSD, PCP, and mushrooms, and the club drugs are at low numbers here. But those inhalants really would make me have some cause for concern. But we don't see here any of the synthetic drugs. And so I'm not quite sure, if they're not being used, or is it the question for this particular purpose is not being asked? Again, those questions asked on the survey. So this is for middle school. Now let's take a look. That's middle school. Now let's take a jump and look at high school. I'm going to do that one more time. So look at that. Alcohol, 7.3% of middle school. Past 30-day use is 21.2% in high school. So in terms of when we do our interventions, we want to make sure that we're hitting youth before they are really looking. Now, look, is the question answered? It clearly is. Do we see flocka? We see flocka now is coming on the radar. We see inhalants look at that data. Can you tell I'm a data geek? So look, 1.1% of use of past 30-day use with the inhalants. Let's go back. But look, 2.8% in middle school. So what is happening with middle schoolers and inhalants? So all of these are the questions that we need to ask as we're looking at emerging threats, emerging issues. So, but look at that. Now we see synthetic marijuana. So my question to you before was, is it even being asked? Yeah, it is, but we're not seeing any rates of use in middle school, but we're seeing it in high school. But look at the prevalence. And someone just said accessibility plays a huge role too. Oh, and synthetic marijuana is not asked on the FYSAS. Well, then that's the answer to that question. Then you would have to use focus groups or get another data source to answer the question of whether middle schoolers are using it or not. Thank you for that clarification. And yes, it comes down to, can they get it? That is one of the biggest risk factors. So I just wanted to spend a little bit of time looking at that so we can see. I want to go back to that synthetic marijuana use is not asked on the FYSAS for middle school use. So that, again, might be, and I certainly don't know if we can ask questions or add questions to the survey, or advocate asking that, but it would be important to find some way to measure when that age of initiation use is. Thank you so much for that clarification. I don't know every instrument, every question on every instrument. Then I just want to come over here to past 30-day use of, look at the pain relievers. We're starting to see, and a really good question there. I'm going to come back to it in just a second. Past 30-day use prevalence of, look at the pain relievers. This is a comparison between 2002 and 2018. And we're really seeing, look at that drop in pain relievers. I mean, that is simply the result of a lot of hard work in your communities at the state level. We're seeing the same with depressants. So we're seeing that there's some really good efforts that are reducing the use of prescription drugs. Synthetic marijuana, we've seen now, but let's also say we don't know if that's going to continue to go down because now we've got the resurgence. Look at the over-the-counter drugs, though. We haven't seen necessarily the rates of decline in the over-the-counter drugs. Same with inhalants. I'm going to come to a really good question here, and it says, can the differences be attributed to middle schoolers' access to inhalants compared to high school's access to alcohol? Is this a question of availability? So that is the last half of my presentation, sort of. Let me just tell you, I often am asked, what is the most important or the most impactful risk factor for youth substance use? And while this is really just Dorothy Chaney, talking based on my experience, clearly it's about access. If they can't get it, they can't use it. So absolutely, part of the questions that I would ask in looking at high rates of middle school use is this is about impulsive behavior, right? That high risk-taking behavior. Maybe their parents or their school doesn't know, that kids are inhaling dust off or whatever it is that they can get their hands on, because it's not on parents or teachers' radar that kids are actually misusing that substance. But kids can't get access to alcohol because they can't at 13 years old, they can't go in and not be asked for ID, but at 18 years old or 17 years old, they may be able to go in and buy alcohol without being asked for ID. So certainly there's different levels in availability and access. And absolutely, that's a risk factor, and addressing access is one of the biggest quick wins for any of these substances, cut off the supply. So student surveys are an effective tool, as we talked about, to show us the rates of use, but we really need additional data such as focus groups to help us identify the why behind the use. And really, like the inhalants, why are kids using? Where are they getting? When are they using? Are they using after school and at home? Are they using in between classes? Are they taking it from the computer lab? Like where? We need to know more information. So the student survey is a good start. A question is, what is the race and gender and class of the focus groups? So that would be depending on, so you would design your own focus group. Work with your school to do that. When I've done focus groups with school districts, I work with the director of curriculum or the director of student services, and they go, they sort of use a formula or an approach that's going to give not just one peer group. You don't want to just talk to the sad students who are sort of we say preaching to the choir, but we want to make sure that we have a cross representation of whatever our community looks like. So if you're in a really diverse community, you want to make sure that you represent that in your focus groups. If you're in a community that appears to be homogeneous, although there's no such thing as a homogeneous community, then you want to make sure that you identify who are the subpopulations. Is there an LGBTQ population within the community? And we know the research tells us that some of those sort of disenfranchised population groups, especially in adolescents, have much higher risk. So we want to make sure that you're right in those focus groups, that we don't just have a conversation with the sad kids that are all honor students that are, that are not and don't have some of the complex risk factors that the other youth do. So it's important to get a real representation. So I just want to quickly look at the risk and protective factors, and they happen at many levels. And I just want to walk through, we talk about risk and protective factors. So I want to just give you a couple of examples of logic models. So we often say that your community is exactly conditioned for the results that you have. And so we talk about our data is then put in our roadmap or a logic model. So we want to look at the problem. We want to say, but why, which is our root cause, which might be availability. But then we say, but why here? But what does it look like in St. Pete's? What does it look like in Tampa? What does it look like in Tallahassee? What is it like here? And then we design strategies. So I'm quickly going to show you the 7 strategies for community change, or the community change continuum. And this talks about how to develop a comprehensive list of strategies. I know that we're running out of time, so I'm just going to give you a couple of examples. And this one's a little bit small font, but I wanted to make sure that I showed you what the 7 strategies are. Now, the 7 strategies talk about providing information, enhancing skills, providing support, enhancing access or reducing barriers, which I always say makes it easier to do the right thing or harder to do the wrong thing. Change consequences, which can be either a incentive to do the right thing or a disincentive to do the undesired behavior. How do we change the physical design? And then ultimately, how do we modify or change or implement policy to make sure that we're changing the conditions in our community? So you'll see that on these logic models or roadmaps, this is a very simplistic logic model that I just wanted to share with you. And you'll see the bottom boxes are your data points, so where you would find the data. So on this one, we'll say youth ages 12 to 18 are using alcohol, and the root cause is access or availability because they're able to get it. And so then we're going to do some focus groups, and we're going to say, well, we see that youth are reporting its retail access. We're going to do some focus groups, and we're going to find out that youth are able to purchase alcohol at some retailers without being asked for ID. So then we're going to map comprehensive strategies to that particular problem. So in this one, we're going to do web-based communication to parents about youth alcohol trends, and we're also going to do retailer education on the legal consequences of selling alcohol to youth. We're going to enhance skills by providing tips to parents on how to set clear boundaries or to talk to their youth about alcohol use. We're going to extend, this is a Wisconsin example, we're going to obtain a scholarship to send our local law enforcement to learn how to do alcohol age compliance checks as a best practice. And we're also going to do some retailer education on how to check IDs. And that may sound like it's low-hanging fruit, but sometimes we know that retailers don't know how to check IDs. We're going to reduce the barrier by working with retailers to make sure that staff are trained in checking IDs. We're going to change the consequences by making sure that retailers are fined for selling alcohol to youth. That's a disincentive. But we're also going to recognize retailers who implement an ID policy. So we're going to send them letters of thanks or a certificate of appreciation. And then we're going to look at policies. What are policies that are going to reduce retail access to alcohol? We're going to make sure that we do alcohol age compliance checks, so we don't have to enact a new law there. We just have to enforce it. And then we're going to encourage stores to have a mandatory ID checking policy. So you see that we've got a list of comprehensive strategies that's going to ultimately reduce the access of youth to alcohol, which is going to mitigate the problem. So take us in the task home. So if we're looking at youth synthetic marijuana use, for example, let's look at that. Well, we might see that question on the FYSAS, and we also may see ER data or poison control call data. Maybe in this case, we're going to do an environmental scan, and we're going to see that youth are able to buy it at corner stores or vape shops or head shops. We're going to actually go around our community and count the number of retailers where it's available. And so then we're going to do some focus groups with youth and maybe with law enforcement. We're going to say, we see that they're available in convenience stores, but, don't they have to be 18 to buy it? And we'll hear from youth and law enforcement that, actually these retailers that are selling these products that really know that they're not safe are selling them to anyone because it's profitable. So that's what we're trying to change. So let's look at the 7 strategies for community change. We would do web-based newsletter to parents about the drug trends. Do they know about synthetics? Education to retailers about the laws restricting the sale of synthetics. education sessions for parents and educators about what synthetics are and what the signs of use are. Provide support. We're going to work with a coalition or a local agency to engage the healthcare sector and law enforcement to develop the education sessions for the parents and educators so parents and educators know what's happening on the street. We're going to translate retailer materials into Spanish because in our local assessment, our assumption here is that some of the retailers' first language is not English. We're going to do law enforcement store visits. So we're going to partner with law enforcement so they're going to walk through those retailers and make sure that they're not selling. We're going to recognize retailers who don't sell by signing in a memorandum of understanding with our coalition or agency agreeing not to sell synthetics. We're going to increase the fine for retailers by working with our local city commission. We're going to change the physical design by providing window clings for retailers. And then we're going to modify or change policy by working with law enforcement to enforce existing ordinances restricting the sales of synthetics and maybe updating or modifying them to include new chemical compounds or drugs. So that's an example, and you certainly can take it and use it, of how to develop a comprehensive list of strategies to address this issue. Now, I'm sorry that we ran out of time. These slides are about engaging the 12 sectors, and this is the SAMHSA 12 sectors. I really appreciate your time on this today and invite anyone who has any outstanding questions to contact me. FADA has my contact information, and you are more than welcome to connect with me at any point in time. I thank you so much for spending 2 hours with me today. Here's the list of references. And again, there's more references and additional resources. And I thank you so much for your time and being an active and engaged audience. So with that, Diane, I will turn it over to you. Thank you so much.
Thank you, Dorothy Chaney, for your time and your resource and expertise in sharing with us today. I'm going to change over. We do have some conclusion logistics to go through here, and I'm just going to go ahead and turn this over to get to those PowerPoints. So when I conclude today's webinar, your browser will take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you'll be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system. This helps connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be Messenger at WebEx. Evaluation will close at midnight on Thursday, January 31st. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day, and please hold for the evaluation. Thank you.